I'll also say on the portal vein side, it's different if you see, like if you're injecting or angiogram of the right liver and you see right portal vein versus you see reflux into the main portal vein.
Correct.
That's a different scenario as
Correct.
well. Yeah.
So low dose Y-90, I think, really kind of sucks. But a lot of these patients, for so many reasons. One, you're not really controlling the tumor. A lot of these are, the shunting is associated with bad tumor biology. And so you're not really controlling the tumor. So one, you're not really doing anything, you're burning a lung dose. Another option is to do TACE or do bland embolization. And I think there are many ways to skin this cat. I would like to give a definitive treatment, not a definitive, but to give a optimal treatment to the patient. So we treat with the intent to TACE as if we were treating it without Y-90 on the backbone. So we use a smaller size particle to start. So we start with 1 to 3s and work our way up. Not as good as Y-90. It's not going to be as effective. More often than not, there's going to certainly be some residual, but maybe the shunt comes down. And then we'll remap within a month of doing the bland.
How successful that has been?
Mixed.
Yeah.
But again, sometimes, and I will say sometimes these patients are just going to have bad biology and you just can't win. And that's where the next step is. So the next one is assuming the high lung shunt is associated with the patient with HCC. I think those patients benefit from a trial of immunotherapy. And I think you wind up going down one of 3 different pathways when it comes to immunotherapy. They get immunotherapy and they progress. And I think they were going to progress whether you did Y-90, whether you did bland embo, or whether they got immunotherapy, or whether they got a lethal dose. They just have bad biology. You can't fix that.
Test of time.
Yes, and that's your test of time. There's going to be patients. So they were never going to win from the get-go. And so, unfortunately, there's no way to succeed there. There's 2 other options. One, they get immuno, they have a great response. Well, then most of the time the discussion becomes, from our oncologist, consolidate this for me, clean it up, knock it down. And then the third option, which is where I actually think the combination Y-90 immunotherapy thing has really swung, is there'll be patients that get immunotherapy and they get disease control. They get stable disease, not disease response, but disease control. And so in those patients that get disease control, the lung shunt goes down, and you can almost flick these things with Y-90. You don't even have to you don't have to hit them with a gazillion gray of radiation. You can do 200, 300, 400, 600, whatever. You can treat those and the tumors respond and like they die. Yeah. And those patients, so there's 2 patients that stand to win in the immunotherapy game. So having tried all of those scenarios, if a patient has a high lung shunt, I really love them to try immunotherapy first.
So a couple of other points to add, all great points. I
also want you to hit, because of your collaborative relationship with RadOnc, is there a role for SBRT in this situation?
So there is a role for SBRT. One other procedure that I hate, but people have described and apparently it works, I've never tried it, is putting a balloon into the hepatic vein, which I don't know if you've ever done it.
No.
I thought it was just too much work, but people at Stanford have published on this. In terms of published data, what has worked and what has not on the TACE versus low-dose Y-90, the biggest study that we have is out of Korea. They actually compared Y-90 to C-TACE, and they showed great reduction of lung shunt. That's why I asked you what kind of TACE do you do? They actually have shown great reduction of lung shunt fraction with C-TACE, followed by Y-90 versus the low-dose Y-90. And I've tried low-dose Y-90 and it doesn't work. So I think low-dose Y-90 is out of the picture. I like the immunotherapy idea. I think SBRT definitely has a role, and C-TACE. If they come across my desk now, I generally do C-TACE.
You do C-TACE, yeah. Okay. Do you feel like it affects, these are usually larger tumors, right? So does it affect your then mapping? You have a lot of lipidol in the area, or you don't feel that?
They're usually larger, so you don't go to the whole, so you don't C-TACE them the way you generally do it as a definitive treatment. You do basically, I don't use particles at the end. If I do a C-TACE and that's all I'm doing, I would do the C-TACE to stasis, and I use bland embo at the back end to kind of make sure it stays there. For these ones, I would use gel foam. And I don't do the whole 100 milligrams of doxorubicin with 2 vials of lipidol. I would do maybe 50, depending on the size.
I like the gel foam idea.
Yeah. I've done close to 10. We haven't published that data. But again, this is all based on what the Korean Seoul National, they have the most vast experience with that.
Yeah, well, and TACE will always have a role. worldwide, right? Not everybody has access to Y-90 from a regulatory standpoint, or just is comfortable with the device, right? So TACE will always be available, and we get a lot of great data out of Asia from a TACE standpoint, specifically C-TACE. Going back to your part about ballooning the hepatic vein.
Yeah. Have you done that?
I have not. I'm curious, if you were going to do that, would you repeat the mapping with the balloons in place before you delivered a dose? I don't know that I would be comfortable just delivering a dose.
But I've always thought about it. If you balloon it,
What happens when you take the balloon?
exactly.
And
Are
what
they
the
not going to be
balloon's
behind the balloon with these beads or particles? And
Well, so then when you're delivering your Y-90, your balloon's coming out hot, right? There are also concerns as you are trying to not have a particle spill in your room, that you need to really be cognizant of. So I mean, like, food for thought. So I don't like the balloon idea, just because, and I wouldn't advocate that for people that tend to be I'm not very clean. Like I don't want to say that I create murder scenes in my cases, but I'm not clean by any means either. And so
sorry, I didn't mean to.
No, you're fine.
I think all these extreme measures we took, many of them stem from the days of sorafenib as the only systemic therapy.
Yeah.
I think with immunotherapy, we should kind of take a step back, as you said, and say, is this the only option available? And many times that is not. And even SBRT and external beam radiation at the time was not as robust, the data, as it is now. So there are other options. You don't have to feel like you're the hero here saving the day.
Well, I still think Y-90 is the hero.
I know
Time.
for like 90% of the time, but there is a good 10%, 15% that could be with other treatments,
And I'm strictly conjecturing here, maybe with the balloons in place, you're shutting down that intertumoral shunting and you get more particles, and so then into the tumor, and maybe the balloon's hot. But I don't know. I don't know if the balloon would be hot or not. I will make a quick comment. Tony Van Brooks, if he's listening, he's my mentor. When I was a fellow, he made a comment. I like to wipe my bloody hands on my gown, on my chest. And then I, go talk to the patient and see how they're doing. And he told me that you should never do that. That scares patients when you have blood on your chest. On your hand there, right? So to your point about the murder scene of the room. So